Hello and welcome to the Sisters for Fitness Wellness Show. I'm Stephanie Gaines-Bryant. Our guest today is Dr. Regina Hampton, and she's with Doctors Community Hospital, and you are a breast surgeon.
Yes, that is correct.
Today we're going to focus on breast care.
Okay.
And let's begin by talking about the fact that Breast Cancer Awareness Month just passed. And so this is not something that you need to just focus on 1 month a year. It's something that you can focus on, that you should focus on year round. Absolutely.
So I look at breast cancer awareness as every day, every month of the year. And it's particularly important, especially here in Prince George's County, because as African-American women in the county, we tend to have higher death rates from breast cancer. And so in my mind, we can't afford to wait. We can't afford to put off anything. We need to be doing our own clinical self-breast exam, checking our own breasts once a month. We need to be seeing our doctor on a regular basis so they can perform a breast exam. And if you're over the age of 40, then you need to be getting a mammogram every year.
You were here last year, and I requested to have you come back because you gave so much good information. Are there any new things happening as far as breast reconstruction goes? For example, if you did have breast cancer and you did have to have a breast removed or both breasts moved rather, are there any new things that are going on research-wise or as far as surgery-wise when it comes to that?
So I think one of the most exciting things that we have is something called nipple sparing or nipple preserving or nipple saving mastectomy. So everyone in the news has heard about Angelina Jolie. She's probably one of the most prominent people who had bilateral mastectomy. She had both breasts removed. And that was because she's a Brca mutation carrier. Which means that genetically she was pre-programmed to get breast cancer. And so she was very proactive in having her breasts removed before she gets that breast cancer. And the surgery that she had is the nipple sparing or nipple preserving mastectomy. And if she were to come in and remove her clothing, you wouldn't notice that she had any surgery because her scars are hidden underneath her breast, and she has her skin and her nipple. So all of that, what you see visibly, is still her. We've just, or her surgeons actually have just filled in the inner part of her breast. And so what's nice about that is for any woman who qualifies, you know, they still get to feel themselves. They get to feel like themselves, because when they look in the mirror, they're still seeing them. And it's really exciting, and really to see the women and see how we've really progressed over the years.
Where does the tissue come from to fill the breast?
So tissue can come from one's own body. We can take tissue from the belly. So, you know, I always tell my patients, you know, we all have that little pooch underneath the belly button.
Absolutely.
That we all hate. Well, that makes a good breast. So some patients can get somewhat of a tummy tuck, and we can take that little pooch, and that can be used to create a breast. We can take tissue and muscle from the back. That can be used. And then we have implants, both saline and silicone. And the implants have been redesigned from the older silicones from the 70s and 80s, and that they're safer.
Because that's what I was just getting ready to ask you. There have been lots of complications when it comes to the saline from back in the day. So what is it like now? How is it safer?
So they've redesigned them. The material that they're placed in now is a lot stronger, sturdier. If they are to break, so if it's a saline, which is just salt water, if the saline implant breaks, you know, it's just salt water. We all have salt water in our body, and so the body's just going to reabsorb it. For the silicone has been redesigned, so if it breaks, and that does not happen often at all, it's not going to be harmful to the body. Usually it can be removed by the plastic surgeon, and additional reconstruction can be done. So there used to be a lot of reaction to the body to the silicone. It was very harmful. In addition, the way the plastic surgeon places the implant is a little bit different. It used to be placed right underneath the skin, and now we add an extra layer by placing it behind the muscle of the chest. So it really protects the implant, and they actually last a lot longer.
We've been finding that there are more and more younger women who are getting breast cancer. Where is that coming from, especially in this area?
So we don't know where it's coming from. We do know that African American women do tend to develop breast cancer at younger ages. In this community where I practice, about 30% of my patient population are under the age of 50. When I look at my colleagues in other areas of the DMV, there is probably about 20%. And I tend to have most of my patients are African American. We're just not quite sure why African American women develop breast cancer at younger ages. I think it's going to come down to genetics. I think one of the barriers to that is we haven't tested and we haven't done enough research on African American women so we can find out those answers. There is some research, and luckily the research community is starting to broaden their scope when they do research and starting to include more African American and Latino women in the research so that we can try and get to those answers.
Are you finding that more African American women have that Brca gene that you just mentioned with Angelina Jolie?
Not necessarily. You know, I tend to be very aggressive in testing, and I find most of my patients do not have the Brca mutation, which I find surprising because I have quite a few of those women who have family histories, mothers, sisters, grandmothers, who've all had breast cancer, and they still test negative, which says to me there's something in that family if you have all those first and second degree relatives with breast cancer. And so it's just a matter of, you know, being diligent with doing the testing. I was on another program the other day, and there was a woman who didn't know that she should be tested, and her sister had breast cancer in her 30s. And so it's a matter of we really need to educate our community so that they can go and ask the right questions to get the testing. And the great thing is testing is covered by insurance.
Yes. You also you also work with African women as well. Do you find any similarities in between African women and African American women when it comes to contracting the disease?
Yes, so African women also develop breast cancer at younger ages as well. And they also tend to have something called triple negative disease, which we see in African American women. And what triple negative disease is, these are tumors that are not responsive to hormones. So we typically like to see tumors that have what we call a hormone receptor that allows the tumor to be able to latch on to our natural female hormones, our estrogen and progesterone, and it uses our natural hormones to grow. The great thing about that is we have medication that can counteract that, that can treat that. When you're triple negative, you don't have that receptor, and so we don't have as many medications to treat a triple negative breast cancer. So we see those types of tumors in our younger African immigrant women, and they can be a little more aggressive, and usually those patients have to get chemotherapy because that's the only therapy that we have in addition to surgery and possibly radiation.
I just want to scream because there's something there. The fact that African American women and African women, that there's some similarities. I just want to scream and tell the researchers there's something there, do something.
Absolutely.
Notice this link.
Absolutely, absolutely. So there is an African American researcher at University of Michigan who's been going back and forth to Ghana. So she's trying to get the answer. So, you know, hopefully within a couple of years we can get that answer. But I think for me, doing my part, I try and do as much testing in my community as I can to try and contribute.
As a breast cancer surgeon, do you deal with the patients from the very beginning of the diagnosis all the way through? How does that work?
So in most cases, patients come to me from their primary care doctor after they either feel a lump or they have some other symptom, breast pain, nipple discharge, or if they've had their mammogram and the mammogram shows an abnormality. So in many cases, the patients will be sent to me. I will do the biopsy or have my radiologist perform the biopsy. And then once the diagnosis is made, you know, I'm kind of the first person in the treatment team, getting the patient hooked up with the navigator and the other oncologists on the team. And we work as a team to figure out what type of treatment this patient needs. We have a team meeting. We meet once a week where it's myself, there are other surgeons, medical oncologists, radiation oncologists, the navigator, the pathologist who looks at the slide, the radiologist. We all literally sit in a room at a table. We'll look at the slides, look at the images, and together come up with a treatment plan. And so what's nice about that is as the patient goes from my office to the oncologist's office, we're all singing from the same songbook and not like, well, I'm the surgeon, I'm saying this, and then the oncologist is saying this. It really makes the patient feel comfortable that we're all saying the same thing as they go to the different visits.
And let's remind everyone too how often you should do a breast exam.
So I recommend doing your own breast self-exam once a month. So about 7 to 10 days after the start of your menstrual cycle. If you're no longer having a menstrual cycle, just pick a day. I always say use your birth date. So if your birthday is September 15th, then the 15th of every month, you should be checking your breasts. And, you know, it doesn't have to be this big production. It can just be in the shower while you're bathing, or your partner can do it for you. But just getting to know what your normal lumpiness feels like, because you're only going to know something is abnormal if you know what's normal.
Exactly, exactly. Let's talk a little bit about breast care. What should you be doing? We used to have this debate, should you wear your bra to bed or shouldn't you? What are some of the things you can do to make sure you take care of your breasts besides doing the mammogram? And I think one of those things would be wearing the right bra.
Absolutely. So, you know, bras are safe. I know there are some folks out there who say, oh, no one should wear underwire bras. So underwire bras are safe. The problem is they're uncomfortable for a lot of women because they're just not wearing the right size. So, you know, doing our own breast self-exam, getting our mammograms on time. You know, I have a number of women who just skipped a year or just waited a little bit longer, but getting that mammogram every year is one of the best things that you can do for self-care for yourself. One of the exciting things is we now have what's called 3D mammograms.
Yes.
So what a 3D mammogram does, it's similar to a regular mammogram. You won't notice a difference in the machine, but it will take a couple seconds, maybe 3 to 4 seconds longer, because what the mammogram is doing I heard a great analogy, it's like a deck of cards. So if you think of a deck of cards, if there's a joker in the middle, you wouldn't really know where the joker is until you go through layer by layer and peel off every card. And so the 3D mammogram does that for our breasts. So it really layer by layer goes through the breast tissue, and we can see that on the screen. So we may not have been able to see that joker on a regular 2-view mammogram, but when we go layer by layer, we're going to find that joker right there in the center.
As far as testing is concerned, how easy do you all make it to get tested? Or people in the community, if we're dealing with people who may be in a lower income area, how can you get tested?
So I think we're lucky in the DMV in that DC, Maryland, and Virginia have the breast and cervical program. So here in the county, we have the breast and cervical cancer program, where any woman can come in and not only get a mammogram free of charge, she can also get a pap smear and get her GYN screening as well. And then if she is diagnosed, then there's a treatment program where they will pay for all the treatment, including reconstruction, if she should need it. So, you know, to me, there just really should be no excuse. I think we just have to get the word out that these resources are available for women in the county.
Going back to the 3D imaging you were talking about, is it as, and I wouldn't say that the regular mammogram is invasive, but is it that same process?
It is.
And if you've had a mammogram, you know what I'm talking about.
Absolutely. So I always like to explain why we do everyone calls it the squeeze.
The
we
squeeze.
Call it compression, gentle compression. And, you know, if we were all to just put our breasts in the machine and not use the compression, we'd all have a lot of lumps and things that are our normal breast tissue that would make us say, well, we should probably biopsy that, and that. When we do the compression, all that normal lumpiness kind of settles out. So just the bad stuff sticks out. And that's the stuff that we want to investigate. It really prevents us from doing more biopsies and more invasive procedures than we need to do. So the compression is our friend. And it doesn't feel like
I never thought of that before. Compression is our friend.
It is our friend. It is our friend. And it has a purpose. We're not just trying to torture women. We really want to find the bad stuff if the bad stuff is there.
So with the 3D imaging, even though it's a little bit different from the regular mammogram, you can see more.
Absolutely, absolutely. So we can look layer by layer through that breast tissue. And that's really important, especially for women that have dense breast tissue, which is a big term.
Does that mean, dense means that if you've got larger breasts, or you can have smaller breasts and they be dense as well?
Any breast size can have dense breast tissue. So dense breast tissue is just normal breast tissue. And when it's kind of thickened, and for women that have more lumpier breasts, their breasts are going to be more dense, meaning that's a little harder for the x-rays to really penetrate so we can see. So that's where 3D really gives us that advantage, where we can go layer by layer and look through all that density to see if there's something hiding in there.
Do mammograms catch, what percentage of breast cancer do mammograms catch? Is it 60%, 90%, 10%?
So it's between 80 to 85% is what they're quoting in the literature. So, you know, we're not at 100%. But
and that wasn't always the case.
Right, right. With the 3D, it's gotten better. And so I always like a three-prong approach. I think women checking their own breasts, getting their mammogram, and then having their healthcare provider check the breast as well. So, you know, women still come into my office saying that they feel their own lump. And so that's why I'm still an advocate for breast self-exam, or the new term is breast self-awareness, being aware of what your normal lumpiness is so that you can pick up something that feels different.
And as you said, don't say I just had it a year ago, so I don't have to go the next year. I'm just not going to do it. Be regular.
Absolutely.
Make it as regular as brushing your teeth or celebrate. And that's a good thing. You said the 15th of September. That's my birthday.
Oh, really?
That's funny that you would say that. But make a date with yourself.
Absolutely. And make it girlfriends. I have, you know, people who, you know, they kind of get their girlfriends and they all go do it at the same time. So, you know, you keep yourself accountable, you keep your girlfriends accountable, you know, make it a fun time.
And sisters too, if you've got a sister who you can share that with.
Absolutely, absolutely. I think, and then it takes the fear off if you're kind of coming together as a group, or, you know, 2 or 3 girlfriends going to do it at the same time.
And earlier we were talking about the different procedures that are available and how things have changed and how you can feel like your natural self. Where before it felt like if you got your breast removed, you were missing a part of yourself. And let's talk about how things have changed with that.
Yeah, so as we talked about, the nipple sparing or nipple preserving mastectomy has really been a game changer. And even some patients who may have come in with a larger tumor that traditionally may have needed to get a mastectomy, we can switch around the order of their treatment. So traditionally it's usually surgery, possibly chemotherapy, and then possibly radiation. Well, if someone has a larger tumor, we can give them their chemotherapy first to shrink down the tumor. And the medications have just become so much better that I've seen tumors literally disappear completely. So then we're literally only taking out a very small piece out of that woman's breast compared to a larger size mass. So we can convert someone who might have needed a mastectomy into getting a lumpectomy, where we're able to truly save the breast.
I interviewed a woman a couple of weeks ago, as a matter of fact, and she is a 3-time breast cancer survivor. What's the likelihood of the cancer coming back?
So every situation is different, and what we're finding is that, you know, no cancer is the same. Even though, you know, we could bring in 10 women who all have breast cancer, each of their cancers is going to be a little bit different. And the other thing we're finding is that the cancer is different in each body, which we're finding to be very interesting, and trying to get to, well, what is that and how is that? Do some people just have better immune systems that allow the tumors to kind of, you know, stay a little less aggressive? Those are some of the things that we just don't know, and we're trying to find out the answers. You know, there are most women who are going to get their one breast cancer if they're going to get it, and that's going to be it. There are going to be some, like your guests, who are going to get that second and that third, you know, cancer. And then we start to think about, well, might there be a genetic mutation? Might there be a BRCA mutation? women who are BRCA mutation carriers, if they have the BRCA gene, they are at a 90% risk of getting breast cancer. 90%. So they're getting it. We just can't tell them at what age. And then they're at a 65% risk of getting a second breast cancer. And then there's also a higher risk of ovarian cancer in those patients as well.
Am I misspeaking when I call it BRCA?
No, Brca, BRCA, it's all the same thing.
Okay,
Yeah.
I just wanted to make sure.
Yeah. No, we're speaking the same language.
We were using the right term. Because it is so prominent with African American women, as we see things like obesity are common, diabetes, very common. Is there some link to maybe diet and nutrition with this?
Well, they do say that gaining larger amounts of weight after menopause can put one at increased risk for breast cancer. And so we certainly, recommend, trying to modify our diets, watching our fat intake, trying to get some exercise in.
But what would that have to do with getting breast cancer?
So when we have our fat cells can hold on to estrogen. And so when you're obese, you're going to have larger amounts of estrogen, and we think that contributes to one getting breast cancer.
Okay. I always knew the statistic, but I wasn't quite sure why it happened.
And, watching our weight is good for our blood pressure. It's also good for diabetes. So it's just, I'm a big believer in the whole body and whole wellness. And so, I think little things that we can do to, increase our health is going to help decrease our risk for breast cancer, colon cancer. All those things can be related to weight as well. So I think as women, we just have to, and it's hard. It's a struggle.
It is a struggle, especially after you reach a certain age.
Absolutely. So I say little things make a difference. Like, we're not all going to be able to go out and do a triathlon. So I say make small changes. And what I often counsel patients is, what's the thing that you like? If it's sweets, okay, cut out potato chips this week. And then next week, cut out cookies. And then add a fruit. So cut out cookies and add an apple. So I think when you can make little changes, that goes towards you changing your lifestyle as opposed to, I'm just going to eat all salads. We're not going to all be able to do that.
And how do we make this, what you're saying, how do we make this as important as getting your nails and hair done?
A good point. That is a good point. I think we have to put wellness, we just have to put it at the forefront and realize that, a lot of things that we may not be able to see or feel, many times we can't tell if our blood pressure is elevated. Many times you can't feel a cancer. But
and you definitely can't feel your blood sugar.
Right, exactly.
You can't feel that.
Exactly. So I think we just have to, I think as women, put ourselves first. We're often taking care of the whole family and taking on much at work, but I think we really have to sometimes just say stop. And you know what? I've got to just do better for myself so that I can be that superwoman for my family and my community. And I think we just have to put ourselves first.
We were talking off air a little bit about women and breast size and things like that, and how a large percentage of women don't really know what size they are. I remember when my daughter, when it became time to buy a bra, because I developed early and so did she, we went and we got fitted. But some people don't, it's kind of like a catch. Can you buy it and see if you can wear it, and if you can't, it goes in the drawer, and if you can.
Right. So I think one thing people should know is that our bra size will change as our clothing size changes. And I don't think we've ever been educated that. So,
no.
Our clothing size can change once a year, once every other year. And so our bra size will change as well. I think it's important that women get a good fitting. And in Prince George's County, that can be a problem. And so I'm aiming to solve that problem. Going to be opening a store called Cherry Blossom Intimates in the spring of 2018, where women can come in and get a good fitting and get educated about bra sizes, because bras range from cup size A through N, the letter N. is a true cup size.
So we're going to bring you back when that time comes, and we're going to talk all about that. We're going to have a 30-minute show on bras.
Sounds good.
We've been talking to Dr. Regina Hampton, and she's with Doctors Community Hospital. We've been talking today about breast care and breast health. You've been watching the Sisters for Fitness Wellness Show. I'm Stephanie Gaines-Bryant. Have a great day.